My name is Caroline Gwynton, and I'm a student at Indiana State University enrolled in the Doctorate in Athletic Training program. Today, I'm going to be discussing using the prayer position when evaluating for a pectoralis major rupture. The pectoralis major provides adduction and internal rotation of the glenohumeral joint. It also elevates the thorax during forced inspiration. The upper fibers more specifically flex and horizontally adduct the glenohumeral joint, and the lower fibers extend the glenohumeral joint. Any type of pec major injury can result in functional and cosmetic deficiencies. Oftentimes, there is bruising over the insertion on the humerus, but there can also be bruising over the muscle as well as deformity at the insertion or throughout the muscle fibers. Most commonly, this injury occurs with eccentric contraction. Oftentimes, weightlifters, while they are benching, do rupture their pec major. It should also be noted that there have been no reported cases of pec rupture occurring in women. Unfortunately, there is no psychometric data for the prayer position. Because of that, I have used a bit of anatomy to help build the foundation of utilizing this test. The pec major can be divided into three different segments. There is the upper, middle, and lower portions. The upper portion originates at the medial half of the clavicle, and the middle and lower portions originate at the sternum and cartilage of the first through sixth rib. All of these portions do insert at the crest of the greater tubercle of the humerus, and it is also important to remember that all of these fibers, as they come together, do form the anterior border of the axillary fold. To perform the prayer position, you're going to have your patient seated. They'll place their hands into a prayer position in front of their body, and they will press their hands together, adducting the humerus. Once you have your patient in the prayer position, you are having them press their hands together, which causes adduction of the humerus. The areas you're going to be observing are the axillary folds. You're looking for asymmetries between the two sides. If there is a deformity present, it will occur in this area right through here on whichever side is injured. Any bruising or swelling typically occurs right over the insertion of the pectoralis major along the humerus, but you can also get swelling and discoloration through the muscle itself. A alternative for the hand positioning, you can switch their grip to this position and they are still adducting the humerus. When your patient is performing this, you're going to be wanting to look for asymmetry of the chest wall. If there is a rupture, you will see a deformity like is shown in this image below. Also, you want to note any loss of strength that may occur. If there is a rupture, the patient may have a significant amount of pain while performing this and may not be able to adduct their humerus well. You want to keep in mind that there isn't evidence for using this test. And because of that, you want to remember your anatomy. Because the pectoralis major does form the anterior axillary fold, and if that fold is disrupted because of a rupture, then it makes sense that there would be a deformity in that area. But again, there is not evidence, so basing it on anatomy I feel is very important. You also want to remember that if this is an acute injury that you're evaluating, the swelling that's present in the axillary fold region may mask the defect that might be there. So you want to make sure that you're performing a very thorough history and observation and pairing it with the prayer position. You also want to refer on for any diagnostic ultrasound or MRI if you feel like there is a positive test. These are the citations that I use throughout the presentation. If you have any questions, please feel free to contact me.